Thank you, the World Federation Against Drugs, and honored guests from multiple nations, the government of Sweden, and my hosts. This is my 6th visit to Sweden to discuss drugs since 1995, and I'm delighted to be here on such a beautiful day. I begin by asking a question. How does a simple ingested chemical derived largely from plants imprint itself on the brain? How does it create sensations that eventually suppress, supplant, surmount, and surpass natural rewards? How do these chemicals transform the brain, personality, judgment, to eventually usurp fundamental human priorities, responsibilities, and pleasures, survival, family, love, intellectual and creative pursuits? Drugs propagate extraordinary hedonic signals. They overpower the signals of natural rewards. They suppress the salience of essential rewards. And eventually they supplant the drive for natural rewarding behaviors. I address you with 5 questions. The first is, should scientific principles affect drug policy? What are current and future challenges? What are recent advances to address these challenges? For it is important to describe challenges. It is equally important to try to address solutions. And the limitations of science. Can science alone achieve goals? Drug rewards are sensed by many different types of brains, and drug control policies are necessary for public health responses. Caffeine, alcohol, nicotine, marijuana, cocaine, heroin, hallucinogens and inhalants, and benzodiazepines are all rewarding in humans, and they are mostly in animals as well. From the lowly fruit fly to a pigeon who will poke uncontrollably for cocaine, to the mouse, to the primate, and to humans. And when drugs enter the brain, because of their unique properties that transcend human and other animal experiences, brain communication begins to change. So we have to have some view of what this brain communication is. It has parallels to human communication. When people speak to each other, there is a person who's transmitting, as I am speaking to you now. There is a message that is the substance of the communication, and there's a receiver. In the same way, when nerve cells speak to one another, our brain has 100 billion of these nerve cells. 100 billion. And each one can have 10,000 connections. Imagine if you Twitter to 10,000 people in the world, one individual, and now consider 100 billion nerve cells twittering through the brain and through the body. When one nerve cell speaks to another, it has a message which is the form of a chemical and a receiver that interprets it. Drugs are imposters of the natural messages produced by the brain, and they affect chemical communication. The brain's chemical anandamide, because the brain has a cannabinoid signaling system. The drug delta-9 tetrahydrocannabinol, which resembles the brain's own chemical message. But what happens after this? They invade the communication system. They begin to change neural circuitry, the wiring diagram of the brain. They begin to change brain chemicals, brain proteins, such as in the case of amphetamine, where in the lower diagram you see a loss of dopamine proteins. They begin to change other proteins. In the case of cocaine, a healthy brain, and in a cocaine-treated addict, a cocaine-exposed brain, you see a loss of other chemicals. They change the wires that communicate one cell with another. They change their shape, the number of connections. They change gene expression. And fascinating and interestingly, there are certain areas of the brain that induce craving, that induce sensations for craving. And this is an area which has just emerged over the past few years. In patients that have had losses, neurological strokes, depletion of a brain center called the insula, for example, they have completely lost the desire to smoke. And it is the only brain region that appears to be consistently lost that is associated with a craving for smoking. Obviously, this is now being studied furiously for other drugs as well. Is this the heart and soul of where drug craving sets in? So addiction can result from repeated drug use in vulnerable populations. And our human priorities, survival, stability, safety, belonging to a family, to a community, our self-esteem, our character and values, our aesthetics, our recreation, all come before hedonism, before selfish pursuit of simple internal pleasures. And when drugs are introduced, we get a complete inversal of these values, so that hedonism, the search, the goal, the drive for a single drug experience becomes paramount, and all these other human values fail, leading to turmoil within the individual and turmoil within the family, turmoil within a community, and within a society. So that the consequences of drug use are addiction, but they're not the only consequences. Prenatal exposure to drugs is linked to premature delivery, low birth weight, developmental disorders. Children of drug-abusing parents have higher rates of abuse, neglect, and higher rates of use, so that we can see multi-generational drug use in certain families. It is estimated that 70% of child abuse occurs in families where the parent is using, abusing, or intoxicated. In the adolescent, drug use is associated with a higher risk for addiction, for poor school grades, dropouts, violence, unplanned pregnancies. In the adult population, work performance is compromised. Increased error rates, absenteeism, injuries, poor health, high turnover, higher healthcare costs. Each one of these is evidence-based and statistical. And in the elderly, poor health, medication interactions, accidents, and memory impairment are a consequence of drug use in this population. We also know that medical and psychiatric conditions occur more frequently in people who have a diagnosis, a medical diagnosis of abuse and addiction. So that drug policy should recruit medical professionals, because their patients are the very perfect example of an avoidable disease that not only creates a brain disease, but also creates other medical conditions or is associated with them, either through causality or through collateral damage. Depression, injuries, overdoses, anxiety disorders, lower back pain. I can go on and on. The list is over 20 medical conditions. So what are the challenges that we face in our nation and globally? We have often debated the concept of marijuana as a gateway drug, and this concept does not still have good scientific consensus. But I can say unequivocally, based on current data, that medical marijuana is a gateway to marijuana abuse. And I will say more of this tomorrow. The abuse of prescription drugs is mounting, and it gives lie to the legalization efforts because most prescription drugs are obtained legally through friends and family free, and yet we're seeing rising rates of use, we are seeing rising rates of addiction to them, and we are seeing rising rates of overdose. Adolescent drug use is another area that has to have an intensive approach for reasons that I will try to outline in the next few minutes. And most importantly, we have to identify people who are engaged in use, not just addiction, but in risky, problematic use, and intervene with them, as well as the abuser and the addicted. Prescription drug overdose deaths are rising much more rapidly than we ever saw with the heroin or the crack cocaine epidemic in our nation. That's one special challenge. The other special challenge that I would like to alert you to is the adolescence. Adolescence is a heightened risk for addiction, and it is partly because the adolescent brain is not fully developed. It has two major risks associated with it. First, the adolescent teenager uses an emotional part of the brain to make decisions. So that the introduction of drugs, the fantasy of drug use, the collegiality of drug use, is a much easier decision for an adolescent than it is for an adult who can think and rationalize consequences. When a teenager is given an emotional scenario to try to address and functional brain imaging is performed on them, they use a certain part of the brain called the amygdala, which regulates emotions, it lowers sensitivity to risk, to sensation-seeking and novelty-seeking. When an adult is given the same emotional scenario, they use a part of the brain, the frontal cortex, which is involved in self-regulation, in judgment, in reasoning, in problem-solving, and in impulse control. So we see that there are marked differences in how the adolescent brain thinks and how it approaches emotional scenarios. And then we also know a second jeopardy, and that is the adolescent brain is not fully developed. These are, again, MRI images of different ages of children from 5 to 20, and it's now known that even at 25 is when the brain appears to be finally fully developed. And during this period, the introduction of drugs could alter the trajectory of neurodevelopment, of brain development. And what evidence do we have for it? We have evidence from animal studies. We have evidence from human studies, simply empirical data. The younger the age of first use, the higher the risk of addiction. If a child uses before the age of 14, they have a 6-fold higher risk to becoming addicted to alcohol than if they begin at 21. And it's about 4-fold at the age of 18. For marijuana, it's a 6-fold higher risk for becoming addicted if they begin to use before the age of 14. But these risks do not end here. They are elevated for the adolescent for nicotine, alcohol, inhalants, amphetamines, cocaine, opioids, hallucinogens, and anxiolytics, benzodiazepines. So the adolescent brain empirically is telling us that it is going to be much more vulnerable to drugs than the adult brain, and prevention programs targeted to the adolescent brain are a public health and policy imperative. The next challenge is that the majority of people with an illicit drug or alcohol disorder are unaware of the problem. They do not seek help. And our policy lesson here is we need to identify people who need treatment and offer treatment. But equally important, if not more important, we need to identify people who engage in risky, problematic use before they have progressed to addiction. Those with a medical diagnosis, 94% go unidentified in our nation. It is not because we wish to ignore them. It's because they ignore the public health system. They don't think they need treatment. They don't seek treatment. 94%. We don't know what these comparable statistics are in other nations in the world. What about solutions? Prevention, intervention, treatment, and reliance on science. What are prevention focuses? Obviously, we need to focus on supply and demand. I'd like to give you a few quick vignettes on prevention concepts that could be applied in practical terms. Centroids, I call them. I just coined the name. Parents as a first line of defense in drug screening and testing. We have to accept that prevention is effective. Anyone who describes this as a failed war on drugs does not know statistics. These are the UN, Director Costa's UN Office on Drugs and Crime 2008 report. In Asia and the world, in the past century, opioid use has declined dramatically. In our nation, drug use declined among adolescents by 25% over the past decade and even earlier. 25% declines are impressive. They are positive gains. And those declines were alcohol, tobacco, steroids, they were marijuana, they were methamphetamines, ecstasy, across the board. We need to target prevention on why people take drugs. Prevention policies need strategies to respond to why people take drugs. One of them is to have novel sensations, feelings and experiences, and to share them, to feel good. Another is to alleviate sadness, depression, hopelessness, and other psychiatric disorders, such as schizophrenia. It's called the chemical coping or self-medication hypothesis to feel better. Healthcare professionals have to engage in these populations. Another one, which I will describe this afternoon much more intensively, is what I call the centroid. In this massive diagram, which just was published by one of Harvard professors, Christakis, and his group, the center is a red cluster. I will describe it later in much greater detail. But these individuals are high marijuana users and sleep very little. They sleep less than 6 hours. And these cluster analyses show that even if a person doesn't know that individual, but they are 4 people away from that individual, they still can be influenced by them. So identifying the centroid, the center party in a cluster of individuals, is very important in terms of prevention strategies. How many prevention programs do we have targeted specifically to parents and universally? We know that if parents strongly disapprove of drugs, compared with parents who have no opinion, drug use amongst their children for alcohol will be 6 times higher for parents who have voiced no opinion. And for marijuana, it's 7 times higher. Parents can have a massive influence on their children, and yet we rarely have strategic plans developed towards parents. If they help with homework, compared with parents who don't help, drug use is lower by a factor of 2-fold, so that parents have an enormous influence. Biometric and verbal screening in schools and healthcare environments and the workplace are also very effective. The U.S. military drug positives were 28% in 1980 until there was a zero tolerance to drug use, and it declined to less than 2% currently. In the workplace, those workplace jobs that test for drugs have lower incidences of drugs than those workplaces that don't. Another intervention policy is screening, brief intervention, brief treatment, and referral to treatment. It's otherwise known as SBIRT, and I've converted it into a noun, or a verb. Have you been SBIRTed today? In a federal program, we found that 22.7% of people who appeared in healthcare settings, nearly a quarter of the population, was in need of an intervention for alcohol or drugs or prescription drugs or a combination. And with this intervention, we found significant reductions in marijuana use, cocaine, heroin, methamphetamine, prescription drugs, and heavy alcohol use. Significant. The World Health Organization has done a similar study, a multinational, and they have received positive data as well. We need to medicalize intervention and treatment using a disease model. And we have to remember, what is harm reduction really? Who benefits from it? Does the individual truly benefit? How many people in this room are aware of people who've been treated, who've recovered, and are angry and wish to go back to a drug-addicted state? Treatment and recovery is a much better option for the individual than normalizing drug use and facilitating it. Would a physician ethically promote continuation of a disease? Think of the medical model. How many physicians do you know would give their patients filtered cigarettes just to keep them happy, just because they are addicted to smoking? We need to reduce marginalization by healthcare professionals. And we need to eliminate the moral weakness versus psychiatric disorder and focus on treatment. Treatment solutions are very complicated. They require multiple recovery support services. Many of these in white could be done in healthcare settings. And finally, I will close with two concepts: the limitations of science. In science, we have facts and figures, and yet, for example, with medical marijuana, the science has not trumped emotion. We've seen this happen in the past through ballot initiatives. So in many cases, we have to feed the science with assistance. And here's a wonderful quote from Arthur Koestler, the late writer, because he was discussing Aldous Huxley and his advocacy for drugs. I profoundly admire Aldous Huxley for his philosophy and uncompromising sincerity, but I disagree with his advocacy of the chemical opening of doors into the other world, and with his belief that drugs can procure a gratuitous grace. Chemically induced hallucinations, delusions, and raptures may be frightening or wonderfully gratifying. In either case, they are the nature of confidence tricks played on one's own nervous system. This is a true photograph of the brain area involved in learning and memory. There is now another colleague at Harvard who's managed to label almost every individual nerve cell with a different color to try to understand the complex wiring of 100 billion cells. And so I close with one thought to you. Within the brain, and within the brain only, resides our humanity. It is our capacity to compose music. It is our capacity to write literature and poetry and create beautiful art and justice and laws and mercy and compassion, and to conjure up DNA molecules and calculus and computers, and the internet, and medications, and theater, and rockets, and to love one another, and to contemplate the meaning of existence, and to visualize galaxies, and to conjure up black holes. We must defend our brains. Thank you very much.